Assalamu alaikum. The topic of today's lecture is thalassemia. These are our learning objectives for this lecture. The word thalassemia has been derived from Greek language. Thalassa means sea in Greek language, and emia means blood. Because this disease was first observed in the blood of individuals living around the Mediterranean Sea, that is why it has been named thalassemia. This is a genetically heterogeneous disorder that is caused by germline mutations, and these mutations decrease the synthesis of either alpha globin chain or beta globin chain. The hemoglobin molecule is formed by two alpha globin molecules and two beta chain molecules. So, if the synthesis of alpha globin is reduced, beta globin becomes in excess. Similarly, if the synthesis of beta globin chain is reduced, alpha globin chain becomes in excess. This results in anemia, hypoxia, and hemolysis. The areas where thalassemia is prevalent includes the areas around Mediterranean Sea, the Asian continent, Africa, Middle East, and the Indian continent. We classify thalassemia into two types, alpha thalassemia and beta thalassemia. This is based on the mutation, whether it is affecting the gene of alpha globin chain or the gene of beta globin chain. So the genes of alpha globin chain, they are present on chromosome 16, and these are two pairs of genes, total 4 alleles. The genes of beta globin chain, they are present on chromosome 11, and this is a single pair of gene. The signs and symptoms of thalassemia result from the imbalance in the globin chains. Anemia is due to two mechanisms: decreased red cell production, which is due to ineffective erythropoiesis. The formation of RBCs is deformed or ineffective because the alpha or beta globin chain is not being formed properly. And another mechanism by which anemia occurs is hemolysis, the breakdown of RBCs. In cases of thalassemia major, the individual will present with signs and symptoms which include fatigue, weakness, pallor, tachycardia, jaundice because of hemolysis, growth retardation, shortness of breath, irritability, dark urine, and bone deformities, which are the result of marrow expansion. In cases of thalassemia carrier, trait, or minor, typically there are no symptoms. The individual is asymptomatic. However, sometimes the individuals may present with mild anemia. Now, regarding beta thalassemia, this is caused by mutations that decrease the synthesis of beta globin chains. The clinical severity of this disorder varies because of the heterogeneity in the causative mutations. The mutations may either result in total absence of beta globin chains, or they may reduce the formation of beta globin chains. The heterozygous carriers, they are protected against malaria. Heterozygous carriers are those individuals in which one gene is normal and the other one allele is normal and the other is mutated. Regarding the pathogenesis of beta thalassemia, there are two categories: beta naught mutations, in which there is total absence of beta globin chain synthesis, and beta plus mutations, in which the synthesis of beta globin chain is reduced. The most common mutations occurring in beta thalassemia are point mutations, which may be of three types: splicing mutations, promoter region mutations, and chain terminator mutations. In cases of splicing mutations, there is an ectopic part that is added into the allele, and this results in some normal beta globin synthesis along with some abnormal beta globin synthesis. So, some of the beta globin chain that is formed is normal, and the other one is mutated. Other type of splicing mutations, these include destruction of the normal junctions, which result in no beta globin chain synthesis. So this is called as beta naught mutations, in which there is total absence of beta globin chain synthesis. In cases of promoter region mutations, the transcription of beta globin chain is reduced, which results in formation of only some of the normal beta globin chain. So this results in beta plus mutations. In chain terminator mutations, there are again two types of mutations: nonsense mutations and frame shift mutation. In nonsense mutation, premature stop codon is inserted, which blocks the translation and prevents the formation of beta globin chains. In cases of frame shift mutation, there is either insertion or deletion that shifts the reading frames, and therefore, again, this results in blockage of the translation process, resulting in absence of beta globin chain synthesis. So, chain terminator mutations, they result in beta knot mutations. Beta knot mutations are those mutations which are resulting in total absence of beta globin chain synthesis, and beta plus mutations are those mutations in which the synthesis of beta globin chain is reduced. So some of the beta globin chain is normal and the other is not formed. When there are reduced levels of beta globin chains or absence of beta globin chains, this results in excess of free alpha globin chains, because now the alpha globin chains do not have any beta globin chains to bind with. Excess of alpha globin chains, they precipitate in the precursor cells within the bone marrow, and they lead to premature death of these precursor cells, which results in ineffective erythropoiesis. Also, when these alpha globin chains they precipitate, they lead to membrane damage in the peripheral erythrocytes or the peripheral RBCs, and this results in hemolysis of these RBCs within the spleen. This is the reason of anemia. Because of anemia, compensatory erythropoietin is increased. This results in expansion of bone marrow, and this results in skeletal deformities in thalassemic patients. Also, in cases of any severe anemia, blood transfusions are required frequently, and this results in iron loading, increased absorption of iron through the GIT, and this can result in deposition of iron in various organs of the body, leading to death. So here you can see in beta thalassemia, there are mutations or deletions in the beta globin chain, which is present on chromosome 11. This results in reduced or absent production of beta globin chain. Excess of alpha chains accumulate, which lead to ineffective erythropoiesis, because the precursor cells in the bone marrow, they are destroyed when the alpha chains they precipitate within the cells. Also, the RBCs that are present in the peripheral circulation, in these RBCs, when alpha chains precipitate, they lead to membrane damage and hemolysis. So, because of ineffective erythropoiesis and because of hemolysis, there is anemia, which results in hypoxia and compensatory increase in erythropoietin. Erythropoietin, when it is increased, it leads to hyperplasia of the bone marrow. Also, because the RBCs that are being formed in the bone marrow, they are not properly functional. So extramedullary hematopoiesis also starts. So the liver, the spleen, the lymph nodes, they also start making blood cells. Now, the clinical classification of beta thalassemia, it is based on the severity of anemia, which depends on the genetic defect that is present. And it is also based on the gene dosage. Genetic defect means whether the beta globin chain is totally absent or it is partially reduced, and gene dosage means whether the defect is homozygous, whether both the alleles are mutated or only one allele is mutated, as in cases of heterozygous condition. So when the disorder is homozygous, when both alleles of the beta globin chain gene are mutated, this results in beta thalassemia major. This is a very severe condition, and it requires lifelong RBC transfusions. Ultimately, hematopoietic stem cell transplantation is required. The other category is beta thalassemia intermedia. It has various genetic interactions, and The globin chain, it is produced, but the formation is moderately impaired, and this results in mild anemia. In this case, only occasional blood transfusions are required. In cases of beta thalassemia minor, this is a heterozygous condition. One of the allele is mutated, the other is normal, and therefore these individuals, they are asymptomatic and they do not require frequent blood transfusions, and but they do require genetic counseling. So here you can again see that this table is showing the three categories of beta thalassemia major, beta thalassemia intermedia, and beta thalassemia minor. In beta thalassemia major, this is a homozygous condition. Both the alleles, they are mutated. So this may be either beta naught and beta naught, beta plus and beta plus, or beta naught with beta plus. All these three genetic variations, they are abnormal. In cases of beta thalassemia minor, this is a heterozygous condition. One of the allele is normal, the other is mutated. And in cases of intermedia, there is variable genetic presentation. In beta thalassemia major, in cases of beta thalassemia major, the anemia appears 6 to 9 months after birth, because this is the time when the hemoglobin synthesis, it switches from the fetal hemoglobin to hemoglobin A, which is the adult hemoglobin. So in these patients, there is complete lack of hemoglobin A, or small amount may be produced. The hemoglobin levels, they are around 3 to 6 grams per deciliter. There is marked elevation of hemoglobin F, which can be seen on hemoglobin electrophoresis, and hemoglobin A2 levels are mostly normal, or they may be reduced. So you can see in the picture also that the normal pattern is the hemoglobin A, it is normally more as compared to fetal hemoglobin, while in cases of beta thalassemia, fetal hemoglobin is more and hemoglobin A is either reduced or it may be normal in amount. On morphology, the blood smear of beta thalassemic patients show hypochromic microcytic picture. So RBCs, they are going to be deficient in hemoglobin. They are going to be small in size. Anisocytosis and poikilocytosis is also a feature. Anisocytosis means variation in size. Poikilocytosis means variation in shape of RBCs. Retic count is slightly elevated. There are inclusions of aggregated alpha chains, which are usually not seen because they are removed by the spleen. You can see in the picture hypochromatic cells, target cells, microcytic cells, poikilocytosis because there is variation in the shape of cells, and inclusions may also be seen sometimes in the RBCs. The arrow is pointing towards basophilic stippling, which is another feature of beta thalassemia. Also in beta thalassemia, there is expansion of hematopoietically active bone marrow because of ineffective erythropoiesis. Erythropoietin and anemia, erythropoietin is increased in the body. This leads to expansion of the marrow. So the bones of the face and the skull, the cortex part of the bone that is eroded, and the marrow part of the bone, it expands. This gives a crew cut appearance, which can be seen in the radiograph that is shown here. So in the radiograph, you can see that the skull, it is giving a crew cut appearance because of marrow expansion, reduction of the cortical bone, and induction of new bone formation. So this gives a radiating type of appearance similar to the crew cut. Other features of beta thalassemia include extramedullary hematopoiesis. So the formation of blood cells, it starts within the spleen, the liver, and the lymph nodes. Extra osseous masses in the thorax, abdomen, and pelvis may also be seen because of RBC production in these areas, and because of frequent blood transfusions. These individuals, they have hemosidrosis, deposition of iron accumulation of iron in the body, and then secondary hemochromatosis, in which this uh, extra iron, it is deposited in the organs of the body. Untreated children, they suffer from growth retardation and they may face early death. Cheekbones and bony prominences, they are enlarged and distorted, as I've mentioned, because of marrow expansion, reduction of cortical bone, and induction of new bone. Hepatosplenomegaly is also a feature which is due to extramedullary hematopoiesis. Blood transfusions may improve the condition, but may lead to complications like hemosiderosis and hemochromatosis. Hematopoietic stem cell transplantation is the ultimate treatment, and prenatal diagnosis is possible for this disorder. In cases of blood transfusions, frequent blood transfusions, these individuals are given chelating agents. Chelating agents, basically they bind to the metallic ion, which is iron in this case, and then they expedite or they promote the removal of excess iron from the body, so that the iron does not get accumulated within the body and it does not get stored within the vital organs. Here you can see a picture of a chipmunk. Because of the skeletal deformities, the individuals of beta thalassemia, they start resembling a chipmunk. So they are referred to as chipmunk facies. And this is because of the skeletal deformities that occurs in these individuals. Now, in cases of beta thalassemia minor, this is more common than beta thalassemia major. These are heterozygous carriers, and they are usually asymptomatic, or they sometimes may present with mild anemia. The blood picture is of hypochromia, microcytosis, basophilic stippling, and target cells. Mild erythroid hypoplasia may be seen. On hemoglobin electrophoresis, there is increase in hemoglobin A2, which increases up to 4 to 8% of the total hemoglobin. Normally, it is around 2.5%, but in cases of beta thalassemia minor, hemoglobin A2 is increased up to 4 to 8% of the total hemoglobin. Fetal hemoglobin levels are normal or slightly increased. So, in beta thalassemia minor, hemoglobin A2 is increased, fetal hemoglobin is normal or slightly increased, and hemoglobin A, it may be normal or slightly decreased. Now, why is it important to recognize beta thalassemia trait? This is because of two reasons. Number one, it can be mistaken for iron deficiency anemia. And the other reason is that genetic counseling is required for the future generations. So if the mother and father both have thalassemia trait, there are 50% chances that the children, the offsprings, they will have the thalassemia trait. And there are 25% chances in the offsprings of getting thalassemia major, and 25% chances of the offsprings being unaffected. If one of the parent has beta thalassemia trait and the other is normal, there are 50% chances that the individuals will be normal, and there are 50% chances that the offsprings, they will have the thalassemia trait. So there will be no chances of thalassemia major in this case. So for genetic counseling, this is very important to recognize thalassemia trait. Now coming to alpha thalassemia. Alpha thalassemia is a disorder in which inherited gene deletions result in reduced or absent synthesis of alpha globin chains. Normal individuals, they have 4 alpha globin genes, as it was mentioned earlier in the slide, that there are 2 pairs of genes for alpha globin molecule. So normal individuals, they have 4 alpha globin genes, and each of these genes, it contributes 25% to the alpha globin chains. In cases of alpha thalassemia, anemia is due to again inadequate hemoglobin synthesis and because of excess unpaired beta, gamma, and epsilon globin chains, which may vary at different ages. It may be because of excess unpaired beta, gamma, and delta globin chains, which vary at different ages. Now, newborns who have excess unpaired gamma globin chains, they form gamma tetramers, which is called as hemoglobin bards. In older children and adults, the excess of beta globin chains, they form tetramers, which is called as hemoglobin H. And free beta and gamma chains, they are more soluble. So therefore, hemolysis and ineffective erythropoiesis is less in alpha thalassemia as compared to beta thalassemia. Because in newborns, the major hemoglobin is fetal hemoglobin, and fetal hemoglobin is formed by alpha and gamma globin chains. Therefore, when alpha globin chains they are deficient, the gamma globin chains they become an excess and they form Bart's hemoglobin. In older children, because the major hemoglobin is hemoglobin A, and this is formed by alpha and beta globin chains. So when alpha globin chain is deficient, the beta globin chains they become in excess and they form hemoglobin H. Now the alpha thalassemia syndromes they are classified by the number of alpha globin genes that are deleted. The severity is proportional to the number of genes that are deleted. If more number of genes are deleted, the disease is more severe. So there are four categories of alpha thalassemia: silent carrier, in which one gene is deleted; alpha thalassemia trait is when two genes are deleted; hemoglobin H disease is when three alpha globin genes are deleted; and hydrops fetalis is a condition in which all four genes of alpha globin chain are deleted. So the silent carrier state, in the silent carrier state, there is deletion of a single alpha globin gene, which results in a reduction in alpha globin chain, but this is barely detectable. So the individuals, they are asymptomatic with slight microcytic picture. In alpha thalassemia trait, there is deletion of two alpha globin genes from a single chromosome or deletion of one alpha globin gene from each of the two chromosomes. The children of affected individuals are at risk of hemoglobin H disease or hydrops fetalis, so genetic counseling is required. Symptomatic alpha thalassemia is more common in Asians as compared to Africans, and the blood smear it shows microcytosis and along with minimal or no anemia. The hemoglobin A2 levels are normal or low in alpha thalassemia trait. In cases of hemoglobin H disease, there is deletion of three alpha globin genes. So the synthesis of alpha chains is markedly reduced. This is most common in Asians. The excess of beta globin chains, they form tetramers, which is called as hemoglobin H. Hemoglobin H has a high affinity for oxygen. Therefore, it does not release oxygen when it goes to the tissues, and this leads to tissue hypoxia. Hemoglobin H also forms intracellular inclusions, which leads to hemolysis of the RBCs and moderately severe anemia. The fourth condition, hydrops fetalis, is the most severe form of alpha thalassemia in which all four alpha globin genes are deleted. In the fetus, because the major hemoglobin is hemoglobin F, and hemoglobin F is formed by the combination of alpha and delta, alpha and gamma globin chains. Therefore, the gamma globin chains they accumulate and they form tetramers, which is called as Bart's hemoglobin. Bart's hemoglobin again have a high affinity for oxygen, therefore they do not release oxygen when they go to the tissues, and this leads to hypoxia. Survival is due to embryonic hemoglobin that forms functional type of hemoglobin. So in the embryonic period, the baby is able to survive, but as soon as the fetal hemoglobin is formed, The tetramers begin to form because of the absence of alpha globin chains and the excess of gamma globin chains. So in this case, there is severe pallor, generalized edema, and massive hepatosplenomegaly. The fetal distress begins in third trimester. Intrauterine transfusions are usually given in such cases. There is lifelong dependence on blood transfusions, which leads to iron overload, and a stem cell transplantation is the ultimate treatment in such cases. So this is all. Thank you.